All right, so again, thank you for joining. My name is Leslie. I'm with Rothman Orthopedics. I want to take the time to introduce Dr. Harlan Levine. He's one of our joint replacement surgeons here at Rothman. He specializes in hip and knee replacements. He's been practicing in Bergen County since 2004. He's been with us here at Rothman for just about a year. He joined us in December of last year. We're happy to have him on our team here with us. He sees patients out of two different satellite offices for us. That is their Montvale office and our Rutherford office. He takes his surgical cases to two different facilities, to Holy Name in Teaneck and also to Hackensack Medical Center, where he also holds the title of Director of Hip and Knee Surgery there. So I'm honored to introduce him for tonight's lecture. And Dr. Levine, I will let you share your screen for the presentation and take it from here.
Terrific. Thank you very much, Leslie. Can you hear me?
I can hear you.
Terrific. Let me bring this up. And great. Okay, is that coming through? Good. All right, so my name, as Leslie said, is Harlan Levine. I'm one of the hip and knee specialists in Rothman Orthopedics. And as Leslie said, I hold the title of Assistant Professor of Orthopedic Surgery at Hackensack Meridian School of Medicine, and I'm the head of hip and knee surgery at Hackensack, and I also operate out of Holy Name. And I thank everybody for tuning in today. We're going to talk about something that's near and dear to me, outpatient joint replacement surgery. Now, this is not a talk about how to do hip and knee replacement surgery. This is a talk about why we do outpatient hip and knee replacement surgery and some of the thought that goes into it, how we have developed our programs and protocols, and how we at Rothman Orthopedics are really practicing the best of evidence-based medicine. So I want to take everybody through some of the history of how we got to where we are today and why we do what we do. So first of all, what is the definition of outpatient versus inpatient? And it's not as clear as you would think. When I first started doing this outpatient surgery, I was performing a patient would come in and have surgery and go home in the same day. But it's really not quite that clear. And if you look into the literature, there really is no standardized definition. So it depends on how things are coded for hospital billing. An outpatient patient may actually stay in the hospital for a night or even two. So it does not necessarily mean that they're going home on the same day. So there's been studies looking at what is the definition of outpatient surgery, and I found this to be fascinating, and I will highlight that here. So if you look at a large cohort of patients that had undergone knee replacement, most of those patients were considered inpatient. But if you look at the inpatients, some of them actually ended up going home on the same day or had a length of stay of 0, meaning they didn't even spend one midnight in the hospital. But more interesting, if you look at the definition of patients who had outpatient surgery, whatever that means, only 11% of them went home on the day that they had their surgery. And 89% of them actually ended up spending at least one night in the hospital. So what is the definition of outpatient surgery? As I said before, it's not so clear. So is it discharge on the same day of surgery? Is it discharge in less than 24 hours? Or in more modern terms, is it a stay in the hospital of less than 2 midnights? So again, we're not going to solve the definition of it, but these are all different definitions out there. But the primary goal of any of these surgeries is to return patients safely home safely home from their surgery, period. And I apologize, those are my dogs barking in the background there. So why is there such interest? Well, we're going to start at a high level here. The healthcare industry on a whole is interested in this for the reason that there are lots of dollars out there revolving around this when you look at this from governmental perspectives and insurance perspectives. So knee replacements used to be required to be a quote unquote inpatient procedure, at least according to Medicare, and that has since changed. And that has also changed with hip replacement surgeries. And why is this important? It's important because these surgeries can now be coded differently and performed in outpatient settings which may offer tremendous savings to the healthcare industry on the whole. And it's big business for some of these companies and industries. So from a high level, there may be tremendous savings when you look at outpatient surgery. And if you just look at the distribution of patients and where they have gone over the years, if you look back at 2011 in Rothman Orthopedics, 55% of patients went home with some sort of home services, 12% were discharged home, but 16 and 17% of patients went to some sort of a facility. And I will tell you, back in 2011, this was very, very aggressive in terms of getting patients home rather than to a facility at discharge. And you fast forward to 2018, 86% of patients were going home rather than to a facility. Very few patients required extraneous services. So there's been real improvement in efficiencies in getting patients back home. So what used to happen, going back historically, when joint replacements first began, the thought was that you'd come into the hospital and you would essentially move in for a week or two. The thought of going home didn't occur to anybody. Patients were usually discharged to a rehab center. And patients really felt, in some ways, incarcerated, as did their families, who were then responsible for looking after them later on. Now patients routinely come into the hospital and are home again within 2 days. I mean, that is almost the expectation out there now for patients undergoing hip and knee replacement surgery. And is this a new idea? And the answer is no. Back in 2004, out of Rush University Medical Center in Chicago, when this happened while I was a fellow there training, we were sending patients home. And we looked at this. So 100 patients received minimally invasive hip replacement surgery. 97% of them were able to be discharged home the day of surgery without problems like being readmitted to the hospital or needing further surgery. And so we showed back in 2004 that a rapid recovery protocol was very safe and effective. We weren't shortchanging patients by letting them go home, and they in fact did wonderfully. And then we looked at the same thing with respect to knee replacements as well. And again, this was published in the literature, looking at 50 patients that had outpatient knee replacements. Again, no short-term or long-term complications for these patients going home, and they had similar clinical outcomes to patients who stayed in the hospital. And then there was a big award given out to some of our cohorts here at Rothman who really randomized patients to stay in the hospital versus being able to go home. And we found that there was, again, no difference in complications, readmissions to the hospital, visits to the emergency room, etc. Patients did very, very well being randomized to one of two groups. So this showed that patients essentially can go home after surgery. So my group, myself and some of my partners that I worked with prior to, and actually still with over at Rothman Orthopedics, looked at our local experience here in Bergen County with outpatient joint replacements. And I was involved in a freestanding surgical center here in Bergen County. We were the first group to be doing this, as far as I know, in the area, if not the country, in a freestanding surgical center. And we looked back at 549 of our hip replacements, and we found some amazing results. First of all, patients were of a normal demographic for patients undergoing joint replacements. They were, on average, almost split male-female. They were not overweight. And ASA score is a measurement of health as dictated by the anesthesiology scores. And the 1.6 is a very healthy score. And here's what we found. This is what was really amazing. And remember, before I was talking about the definition of outpatient surgery. This truly is same-day surgery. Our patients, from the time they got to the recovery room to the time they were discharged home, was about 7.5 hours on average. So from the time surgery ended to the time they were discharged, about 7.5 hours. From the time they got to the recovery room to the time they were up and walking, about 2.5 hours, which is really remarkable. You know, in the old days, the thought of getting somebody up walking the day of surgery was absolutely not even thought of. Now it is common. So we showed in this study that outpatient surgery was absolutely safe when performed in appropriately indicated patients, and that there were no medical or surgical consequences that put patients at risk by performing outpatient surgery. So we have found that there is really a big change in patient expectations compared to prior years. So when patients originally had joint replacements, as I said, they expected to be a patient and they would be in the hospital for weeks and they would be doted on and taken care of. This is what patients expect now, not all, but some. So pay attention to the patient on the right. So patients, our expectation after surgery is different. They're not expecting to stay in bed. They expect to get up and walk and move. And especially as this gentleman on the right with the hip replacement, there's no reason that he can't be up and active as he feels comfortable doing so. So what happened and how do we get to where we are? So it wasn't so simple as saying, hey, we're just going to send patients home the same day they had surgery, the next day. We really needed to institute changes in protocols, changes in mindsets, changes in testing that may need to be done. So we have gone through several stepwise approaches to reducing burden on patients, things that we thought that they needed to do or that we needed to do for them that really were extraneous. And we've been able to pull those away and give patients wonderful outcomes with their joint replacements and allow them at its essence to be able to go home after a short stay or a true outpatient stay in the hospital. So part of this starts with patient expectations. What do we talk about in the office? There are patients who come in and they know now that they're having an outpatient surgery. They expect it because people they know have done this and have done very well. They come in asking for it. Other patients still think that surgery is done in the hospital. You're going to have a several-day stay. Worse yet, you may have to go to a rehab center, all of which is absolutely not true. So counseling starts in the office, and I have these discussions with patients all the time. But it's not just myself, it is a team approach. It's my nurse and my physician's assistant in the office. It's discussions with our nurse practitioners and educators in the hospital with whom they discuss this with prior to surgery. And it's understanding that home discharge and a short stay in the hospital or a same-day discharge is absolutely normal and absolutely appropriate for them. So what are the keys to success in outpatient joint replacement surgery? Well, I talked before about patient selection, and I'll get into that again in a little bit. Adherence to protocols that we have developed that allow patients a safe recovery, a standardization of care so that there is really no surprises about what patients need, creating efficiencies within the hospital as well to give patients, again, what they need, and on the back end for us in the hospital to make sure that we have the resources available. And then, of course, doing what we can to minimize complications that patients may encounter. In reality, this is absolutely no different than any other surgery that we perform for patients who are going to be staying as an inpatient. There is really no difference. So patient selection is important. Not all patients can go home the same day.
Sorry, Dr. Levine, one question. Do some of these factors vary based on if a patient receives just stitches, or does every patient receive staples with surgical?
Oh, that's an excellent question. So the question is, how do we close the wounds? And does what a patient has over their wounds determine whether they can go home or not? The reality is, no, it doesn't make a difference. A wound can be closed with a surgical glue, which is what a lot of us do use. A wound can be closed with staples, or a wound can be closed with stitches or variation thereof. And that would have no impact on whether you can go home. So that's a good question, and no, that would have no bearing on that. But getting back to this, patients need to be motivated. They have to want to do well. They have to be willing to get up and walk and move. And that's very important. Most patients, as I said, do. There are certain patients that really should not have outpatient surgery and do need to stay in the hospital. They have a higher risk for complications, and I'll get into this in a little bit. But patients who have, untreated OSA, that stands for obstructive sleep apnea. So people out there who have a lot of snoring should be checked for sleep apnea. Patients that come in with low blood counts or anemia, patients that have morbid obesity, and patients that really don't have a support system around them as well. That obviously is important, and this has been shown in studies looking at risk scoring of patients. Adherence to protocols, as I mentioned, we have developed protocols within Rothman Orthopedics, and other groups have created similar protocols to help with the before, during, and after of a patient's experience. And it doesn't have to be as complicated as that picture that we have over here on the right from the phone company, but these are important protocols nonetheless that allow us to provide patients outpatient surgery in a predictable fashion. So again, part of this starts with standardizing care, avoiding nausea or vomiting, as an example. Such an important thing. What can we do to help prevent patients from feeling ill after surgery? If they feel ill, they're not going to want to get up and do anything. So certain medications that we can use before and during and after surgery may help with this. We don't want to put drains in people or put other things on them that may encumber them and make ambulation difficult. We want to make sure that they don't get hypotensive or feel dizzy when they get up and walk. So making sure that they are not dehydrated is very important. We would like to avoid putting catheters in their bladders if possible, or if we do put them in, take them out quickly. And again, we want to ensure that they are eating and drinking. And again, early mobilization. We find that getting patients up and walking quickly really can be very helpful in those first few days of recovery. So again, that gentleman on the top image here is what patients used to look like and feel like on post-op day one. We coddled them, they stayed in bed, they didn't do much of anything. And the patient down below is also post-op of one day from surgery, and here he is, he's home and he's walking and feeling great. So you can do well immediately after surgery. You don't have to stay stuck in bed. And here he is kind of showing off with his walker. He's just carrying around. He probably doesn't even need it. So you can get up and move very quickly after these surgeries if you're not nauseous, if you're not dizzy, and if you're comfortable and confident. Obviously, you have to be stable. We want to make sure that you're eating and you're not nauseous and going to the bathroom, as I said. So what is not needed? As I said before, we have also taken things away that are not needed. The poking and prodding and the testing and the cumbersomeness of surgery. So lab tests. Most lab tests are not needed after surgery. So why stick a needle in a patient to see what their blood count is? Usually there's not much we're going to do anyway. But most patients do not need transfusions. Looking at their chemistry, their sodium and their potassium. Most patients don't have problems with that. So why are we looking at that? And a big one is anticoagulation. There is a risk of developing blood clots after these surgeries, or what we call deep venous thrombosis. And we've spent a lot of time looking at that. And one of my partners in Rothman Orthopedics, Jay Parvizi, has really been a leader in this, looking at different anticoagulants and figuring out what works well, what's the most efficacious and the least burdensome to patients. And guess what it is? It's aspirin. So our patients now go on aspirin after surgery unless there's a contraindication to aspirin. And what this means is that it's easy to use. You don't need a special prescription. You don't need blood testing like you did with others. You don't need to give yourself an injection, and you have a much lower risk of bleeding with aspirin than you do with some other very potent anticoagulants. So it's very easy to use, very efficacious, and has a very, very low risk profile. So again, to allow a patient to be discharged, they have to be comfortable. They have to have been able to pass certain metrics with physical therapy, which we'll get into, and they have to be medically stable, as I got into. So we have to control their pain. They have to be comfortable with the idea of being discharged and that their pain is well managed. And they have to know that there's help for them if they should get into trouble well at home. So here's a patient about to be discharged on shortly after surgery.
What can you do with your day? Well, I can pick it up like that. that's what I can do.
So, those who will recognize that this is a patient who had a recent knee replacement, and obviously to be able to move like that, to be able to sit like this, and to be able to have a conversation like this, she must be comfortable. And when I talked before about protocol-driven medicine, and this is a great example about medications that we are able to use before, during, and after surgery to keep patients comfortable. And you'll notice the names of these aren't as important, but there are many of them. And we use these quote-unquote cocktails to lower a patient's pain, right? And to lower their demand for any one type of pain medication. And most specifically, what we like to do is to lower their demand for narcotic medication. We all know problems with narcotics out there in terms of addiction. Again, that's certainly a crisis in this country, for which we have an initiative within Rothman Orthopedics. But narcotics on an individual basis can make you sick, nauseous, constipated, hurt your appetite, etc. So while they may help with pain, their side effects also may keep you from wanting to move and get out of bed and be able to get home. We have cocktails for patients use when they get out of the hospital. In this case, Tylenol, gabapentin, which is a medicine for nerve-mediated pain, metaxalone, which is a muscle relaxant, which we don't typically use, but it's available. Meloxicam is an anti-inflammatory. And then on the bottom, tramadol, oxycodone. Those are narcotic medications or narcotic-based medications available to patients on an as-needed basis. But the goal is to not really need those. Physical therapy is important to be able to be discharged. We want you to be able to walk. 80 feet is a reasonable number. To be able to go up and down stairs. Obviously, many patients have stairs in their house and need to feel comfortable getting out of their car and going up and down stairs to the house. They have to be able to get in and out of the bathroom. They have to be able to get in and out of bed. And they have to be able to dress themselves and perform their normal basic activities of daily living. So this is what physical therapy does with patients before they leave the hospital. And some patients will even do some therapy prior to surgery so that they're familiar with what they may need to be doing. And in terms of discharge, we have shown again in our group, some of my partners here have published on this, that there is no place like home after a joint replacement. It is the best place to go. There's no increased risk of complications in going home versus a place like a rehab center, that there's no difference in functional outcomes or pain or satisfaction. But the one thing we've learned with certain patients, not all patients, there are some patients that aren't ready to go home on the day of surgery or even after one day. And those patients may need an extra night in the hospital to meet their therapy goals, to make sure their pain is controlled and to make sure they're comfortable with going home. But again, we would prefer patients to go home. It is the safest place for them. Some patients go home with home care, but we've also shown in our group that home care, like having a nurse in your house, doesn't really add much other than expense. They're not improving the quality of your care, and in some case, there may be a counterproductive. So you don't need a nurse in your house or formal home care for most patients. And looking at physical therapy, the convention has been traditionally that you have to do physical therapy, real physical therapy after a joint replacement, and that if you don't physical therapy, you'll never do well. Well, we have also shown in our group that that is probably not necessarily true. So a study looking specifically at hip replacements looked at outcomes for patients, and they did wonderfully without physical therapy. Just get up and walk and or follow a program on your own. And then unsupervised therapy, meaning exercises that you do on your own, is just as effective as therapy directed by a physical therapist. And if you think about what this really means from a practical perspective, to do physical therapy with a therapist, you got to get out of your house into a car and you need to drive somewhere. And then you need to pay for that visit. You will have co-pays. So there's the burden of getting out of your house, and if you're not driving it, that might mean somebody needs to take you. And there's the expense of it. And if you think some patients have co-pays of $50 a visit, plus or minus, when they go to see a therapist. And if you're doing that 3 times a week and you're doing that for a month or 2 or 3, that really adds up. So there are some real advantages to not being burdened or tethered by the need for formal physical therapy. There's the thought that knee replacements are different, but they're not. We've shown again that patients following a program on their own do just as well as patients who work with a formal physical therapist. So again, this may not be for all patients, but many patients do very well with this. So in reality, about 2/3 of patients probably do not need formal physical therapy. Again, advantages for the patients are convenience and expense without a compromise of quality or recovery. Patients also need to be able to access help. One area of concern is, well, what if something happens? What am I going to do? Well, so it's our responsibility as physicians and as hospital systems to be available for our patients. So patients have numbers to call. We have nurses in our practice available. We have nurse practitioners in our hospital who are involved in your care while you're in the hospitals, and then they reach out again afterwards and are available. So patients really are never left alone. But one thing we love to avoid for patients is just, the knee-jerk reaction of, I have to go to the emergency room. So we want to hear from you before you do that, unless, of course, there's a real emergency. We have you come into the office, we talk on the phone, we exchange pictures, and many calls or whatnot can be, many calls for help, can be addressed that way. They're really not major concerns. Outreach to our patients is important. We try to reach out to them the day after surgery, by the end of the week, before the weekend, et cetera. We do that through the office. Our nurse practitioners in the hospital also do that. So there is constant contact back and forth for our patients. So I've waited all the way to get to this slide to talk about surgery and surgical approaches, and this may be something that's on people's minds. We talk about hip replacement surgery and how's it going to be done? Where is the incision? Is it in the front? Is it in the side? Is it on the back? In knee replacements, we talk about how is a knee replacement going to be done? Are you using a robot? Are you doing a partial knee replacement? And I just want to say the following. What's more important than about a surgical approach or about a specific individual technique is the concept of following the general principles of surgery. We try to miniaturize the surgery. We try to lessen the invasiveness of that surgical procedure. That's really what's most important. And in the hip world, whether we do a direct anterior hip replacement or a mini posterior hip replacement, these patients really do equivalently. There is not a major difference between those two approaches. So one doesn't necessarily allow you to have an outpatient surgery and the other preclude you from having an outpatient surgery. And the same is true in the knee world. So again, we want to adhere to the principles of surgery, gently handling the tissues, maintaining hemostasis, meaning, again, handling the tissues well and minimizing bleeding and trauma to them, and doing efficient surgery. We don't want to be in a surgery with you for 2 hours when really we can do the surgery in 45 minutes and get the same job done. Getting in and out of the OR efficiently, doing good quality work, obviously, is important. So patient selection, who gets outpatient surgery versus who really shouldn't? And in a nutshell, you need to be healthy. So here's one study from the Journal of Arthroplasty from 2017. Patients who were discharged in less than 24 hours were likely to be a little younger, healthier, not overweight, not on steroids, versus those who weren't, were elderly, were sicker, had a history of smoking or bleeding problems. In another study, patients who looking at the difference between short stay in the hospital versus longer stay in the hospital and risk of complications. In this study, they found that 6.9% of complications happened after 24 hours. So even for patients who spent the night and went home after 24 hours, could have a complication. And the risk for those patients are those who again, had COPD, so bad lungs, who had congestive heart failure, coronary artery disease, or liver cirrhosis, pretty significant risk factors. So I would say most patients do not have these, And those who do, we know about already and are not encouraging to have a short stay surgery. So these are patients that end up staying in the hospital and are watched after. And admittedly, some of these patients probably shouldn't be having surgery at all. But again, that's not the focus of this discussion. In another study out of my old training grounds, looking at complications after outpatient surgery, we found actually that patients who had outpatient surgery had a lower rate of complications. Maybe because they were healthier to begin with, but maybe because we were also so protocol driven in terms of how the patients were taken through their surgery. And then lastly, looking at patients in the Medicare age, so 65 years and older. So this is something that's a newer thought as the Centers for Medicare and Medicaid Services, which really drives payment to hospitals for Medicare populations, has really defined what we're able to do. So until recently, we were not able to do outpatient joint replacements in patients who had Medicare. And as I showed in those earlier slides, Medicare has recently allowed outpatient joint replacement for Medicare age patients. And so we've looked at who is safe to go home the same day or the next day in a Medicare population. And what we found is that risk factors for patients going home in this group include patients who have had a general anesthetic versus a regional, like a spinal, or patients that have diabetes, or again, patients that have bad lung disease, or poorly controlled blood pressure, or severe kidney disease, or an ASA score 4. Again, that just means, generally very unhealthy, or patients who are overweight, or again, patients who are very elderly. And I would argue age 75, greater than 75 is not very elderly. We have patients in their 80s and 90s who are very, very healthy. And what we showed in this study is that 23-hour stay, meaning coming into the hospital, having surgery, and going home the next day before you've been there for quote unquote 24 hours, may be the sweet spot in taking care of these patients who are eligible in a Medicare age for short stay surgery. So being Medicare age does not exclude you in any way, shape, or form from being able to have short stay surgery. So what about patient satisfaction? So we look at how well have patients done with outpatient surgery or short stay surgery. Patients are ecstatic. We have taken them out of the hospital. They no longer play the part of a patient laying in bed for weeks waiting to be doted on. These patients are up, they're mobile, they don't feel ill, they feel like they've made an investment in their health, and they are on the road to recovery quickly. So multiple studies have shown this, 96% satisfaction for patients undergoing hip replacement surgery. And, from our colleagues out in New Albany, Ohio, where they do a lot of outpatient surgery as well. I mean, 98% good and great and good satisfaction for patient scores, and an admission rate of 2% or less, which is outstanding. Physicians are also very happy with outpatient surgery. We are, it's sort of redefined a lot of what we do. We have control in a large part over the flow of our patients within the hospital or outpatient facilities. So it's really been very, very helpful for us to provide high quality, excellent care for our patients. And then, I started talking about the economics of outpatient surgery, and I want to finish on that as well, taking it back to a high level about what this does for the healthcare economy on the whole. So we found by doing outpatient surgery and really reducing so much of this extraneous stuff, we've been able to reduce the total cost of care by probably $7,000 a case on average, and that's amazing. And if you look at the difference in cost and where dollars went in pre-2014 to where we are today, in 2014, more than half of the cost of a surgery was after a patient was discharged from the hospital, with rehab centers and a lot of extra physical therapy and doctor's visits and testing and whatnot. And by really analyzing what we do and again streamlining so much of it, we've been able to reduce the total cost of these surgeries, and I'll go back one slide, on an average in this series of $27,000 per surgery to about $18,000 per surgery now. And we've been really able to streamline where all these dollars go. And what does this savings mean? It means that there's more dollars out there that can be spent in the healthcare economy in other areas for patients. So it's really been very, very successful, not just for individual patients, but for orthopedics and the healthcare economy on the whole. So in summary, through thoughtful medicine, we've been able, and evidence-based medicine, we've been able to create very effective, very efficient programs for outpatient surgery. The goal, again, is allowing patients to get up and walk and move and feel comfortable and get home safely and confidently and be excited about getting into the next phase of their recovery. I thank you all for your attention here, and certainly would be delighted to answer any questions that you may have.
Thanks, Dr. Levine. I did get a few questions here that I'm just going to read off if you don't mind.
Of course.
Some of these are a little bit more specific to once you do get the replacement surgery.
Great.
So multiple questions on knowing what types of exercises people are not allowed to do post-surgery.
So that's an excellent question. So there are some protocols and restrictions that we have for patients. And a lot of this comes into sort of preoperative education. So patients who are going through any surgery, whether it's inpatient surgery or outpatient surgery, usually are going to some sort of joint replacement school. Now, I know at Hackensack we do this, and we've been doing this for many years. I was involved in putting this together. So questions about what exercises you'll be doing afterwards are discussed in these classes, and you leave with handouts of exercises that can be done. We have those in our offices as well, and I actually give those to my patients before surgery so they have an understanding of what they're going to be doing and what's expected of them. We have different programs as well, web-based programs that for physical therapy that patients can follow on their own. We've been doing that in Rothman Orthopedics for some time. I've been doing that as well in my old practice, and again now. We have partnered with other applications. Something I've been involved with has been a joint venture with Apple Computer and one of the implant manufacturers, and we have a program that you can use through a phone and a smartwatch to help guide you through your recovery and exercise programs. So there is a lot of information out there that we provide you with in different pathways to do this.
What recommendation would you give for someone if they've already had injections in their knees, but they find that they're not working for them?
Well, I mean, again, it depends what the disease is. So just assuming somebody has arthritis and has been treated non-operatively, meaning they have tried some anti-inflammatory medications if they can tolerate them, or acetaminophen. They have tried some exercises on their own, or maybe even worked with a physical therapist, and they've gotten to the point where they have now tried injections. And there's different types of injections. There's steroid injections, and the gel injections are what we call viscosupplementation. So none of these things cure arthritis. None of them prevent arthritis from progressing. We always encourage patients to lose weight if they're overweight. That reduces the stress on the knees. But if you've gotten to the point where the shots themselves and other modalities aren't providing enough improvement, then it might be time to start thinking potentially of surgery or looking for other modalities. So, when these things that I mentioned fail to provide adequate relief with respect to pain or adequate improvement with respect to function, then you might start to think about needing surgery. And we know that the better shape somebody is in when they go into surgery, the easier the recovery is going to be. So if somebody has significant muscle atrophy and has lost a lot of strength, or they have contractures and have lost a lot of range of motion, Those two factors alone will make the recovery more challenging. So you don't want to wait and wait and wait and wait until you're so riddled with arthritis and the sequela of arthritis that it really can compromise your short and long-term recovery potential. So again, if the injections are no longer helping, it's probably time to see an orthopedic surgeon and figure out what might be the next step for you before it becomes, much more challenging.
I'm going to even take it back a notch before injections are presented. Can you briefly explain what type of studies are performed on a patient to determine their joint injury?
Sure. So the average patient that comes in to see myself or one of my joint replacement colleagues will come in and get, if they don't have it, they will come in and get an x-ray. And there's certain views we want to see. So sometimes patients will come in with x-rays from somewhere else and we'll get new x-rays. But we start with x-rays, plain old radiographs. For the world of arthritis, that tells us almost everything that we need to know almost every single time. Studies like MRIs, CAT scans, bone scans, other imaging modalities usually are not necessary for what we do as joint replacement surgeons. Those studies have a time and a place. For example, somebody who has a sports-related injury in an otherwise pristine knee, an MRI might be necessary or useful to make diagnosis. But for arthritis, often plain radiographs are more than sufficient. And not just sufficient, are better than these other studies. They are clearer in defining the pathology. So x-rays really are what we prefer to see.
Dr. Levine, thank you so much. I didn't have any other questions come in at this time. I am going to send in the chat here Dr. Levine's link to his bio on our website. I did have a few people question about other locations outside of the ones you are at. To find out if there's a Rothman location in your area, again, I would go to our website. It's rothmanortho.com. From there, you can search by our office locations and also by specialty, to see who is in your area. Again, we have recorded this event this evening, so I will be sending out a recording to everyone. Thank you again, Dr. Levine, and thank you everyone for joining us this evening.
Thank you, everybody.